doesn't come out. So after 10 to 12 weeks, we can easily replace the tube, and we do that under, again, a very light general anesthetic, and we put in a button, and you can see a patient who, on the top there, on the top right, that had a tube just removed, and you see there's still a little sore from the where the T-fasteners were. So this is a procedure that we like, but it's not without its problems. And we've had no wound complications, which has been a big improvement. At 3 weeks, we had one patient who had the balloon on the catheter migrate further in and actually blocked the end of the stomach, and we had to pull the tube back. We recognized what we had done wrong in that particular case. We had failed to put a special type of tie around the flange of the catheter that would have prevented that from occurring. We've had 3 patients that developed a localized skin erosion at the edge of the flange, and you can see this is one such patient, and this heals very quickly once the tube is removed and replaced with the button. Granulation tissue occurred in about 1/3 of these patients, but all responded to topical treatment. So what about the skin care of gastrostomy sites, regardless of which approach is used? We normally make sure that the tubes are clamped or closed prior to bathing. We use very mild soaps to avoid irritation and abrasion of the skin. Sometimes early on there's crusting around the G-tube site, and we use 3% hydrogen peroxide but dilute it in half and apply a saturated gauze or a Q-tip around the edge to help get the crusting off and make the area a little cleaner. If you continue to use hydrogen peroxide for a prolonged period of time, it will cause irritation and drying out of the skin. So it's really designed for a short-term usage. And then we put a thin layer of Mepilex light underneath the G-tube just to create a little cushion so that the tube flange itself doesn't irritate the skin. What about the feeding regimens and strategies with these patients? These tubes are mechanically designed to accept formula, milk, some juices, selected medications, as well as water. They're not mechanically designed for blenderized food, although the old traditional G-tubes were, because they didn't have these flap valves in them like the buttons do. The one thing about having a G-tube in many of these children and young adults, medication compliance improves dramatically. And so they can take their vitamins, they can take their medications, they can take their pain medication, et cetera, in ways that make them more compliant. Now, there's a variety of ways to feed patients with G-tubes. You can do bolus feedings, and so these bolus feedings can normalize a child's schedule and coordinate it with the schedule of the family. Over time, the bolus feedings allows for normal expansion of the stomach, creates a gastric reservoir. Many of our EB patients have very small stomachs because they're used to getting small volumes of feedings. And those small volumes of feedings, if you exceed it, they get nausea, vomiting, and it's really distressing for them. They get abdominal discomfort. So these bolus feedings will gradually increase the reservoir of the stomach. Also, when you use bolus feedings, it's very helpful to allow a child to sleep at night. And so some kids do much better having their feedings during the day, and there's no interruption of their sleep at night. If you do bolus feedings, it's important to keep the child upright to minimize reflux afterwards. But this is a very effective way of managing a diet. Unfortunately, not every child gets enough in during the day, and sometimes we have to supplement these with continuous feedings at night. This requires a pump. It requires the parents being trained how to manage those pumps, but it's very effective at getting calories into patients. Reflux can be an issue if the volume of feeding rate is too high. And many of these kids will wake up in the morning feeling full, so they will not eat breakfast. They don't want breakfast. So these are sort of the consequences of that, but it's not that it's bad or good, it's just you need to understand why that occurs. Now, when you feed a child who has a gastrostomy, especially young children, it's important to make sure there's oral stimulation during the feeding to promote normal development. Participation at the dinner table or routine family eating activities is helpful when you're giving a G-tube feeding. It promotes socialization and it really helps the child be integrated in the family activities. The other thing that we've observed, and this has actually been physically measured in a number of studies, where you have real feeding stress issues, that the feeding process may be 8 to 10 hours in a day, and it takes up everybody's energy, particularly the primary caretaker energy. So you can reduce that to somewhere between 2 and 3 hours a day by having a gastrostomy tube when you have those circumstances. And so that this really is liberating for some families and for the child. It increases the opportunity for appropriate socialization, for school activities. It reduces caretaker fatigue and reduces parental and child stress. So gastrostomies really do have a very positive effect on the patients who really require it. Those who are able to take adequate enteral feedings in and are integrated in their family and social activities, they don't need a gastrostomy tube. But those that do really benefit from having such a tube. So in summary, there are a variety of gastrostomy techniques that are effective. Significant complication rates are 12%. Minor complications are even more common. The non-endoscopic push gastrostomy is both effective and has fewer wound complications, but these patients still have some complications associated with the tube placement. This approach, this latter approach, has not yet been used in very small infants, so our preference for a child under a year of age would be to do a small open gastrostomy. The incision is only about 1.5 to 2 centimeters to do the procedure. So thank you, and be happy to address any questions.
I'm coming.
Yeah, my daughter had trouble eating when she was an infant because of all the blistering in her mouth, so she's got a G-tube, Mickey. What period of time would you give between going from all oral intake to removing of the G-tube? Would you recommend? And what do I expect when her G-tube is removed? Is it a surgical procedure or what?
Let me address the latter part of the question. If you remove a G-tube 6 months or more after it's placed, generally the lining has epithelialized, so you have a persistent tract. So if you take out a tube in the first 6 months, the hole will close usually automatically without a surgical procedure, but afterwards it tends to stay open, so you will have leakage of gastric contents. And so many of those children will require a small surgical, usually an outpatient surgical procedure to close the stomal opening. The issue of can you remove, or what should you remove, or when you should remove, is really individualized. If the child is doing extremely well and seems to be growing well and maintaining that growth curve for some significant period of time, and I would say at least a year or two, then removing it may be reasonable. I've had a number of patients who have done that. They've removed the tube, and 4 or 5 years later, when they've gone through adolescence, they've had growth failure issues again and required a replacement of the tube. Now, you can replace it with the similar type of procedure with the percutaneous approach, and they usually tolerate it quite well. But it's a highly individualized issue in terms of when or if you should remove it.
Thank you.
I was wondering what you recommend if my son's button leaks quite a bit. Like, what can be, does it mean it's too small, or, I mean, what does that necessarily mean, or what can be done to stop it?
That's a very common problem, and there are several reasons why buttons leak. One is that the tube is too long, and so there's a lot of play in the tube. So even if it's 3 or 4 millimeters too long, which doesn't sound like a lot, that may be enough to have the gastric contents leak by. Another reason is the balloon may not be adequately inflated. And so we recommend, once the buttons are in place and healed, the site is healed, that once a month that you check the volume of the balloon. And some of these buttons hold 5 or 6 milliliters of fluid. Some of them are designed to hold 10 milliliters, especially the larger sizes. If you overinflate, sometimes you can stop the leakage. The problem with overinflating is that sometimes that can put too much tension on the abdominal wall, and you can, over time, actually dilate the tract and then end up with a situation where you have a massive hole that really is hard to manage. So I would recommend that if that's the case, that you see your surgeon or somebody who really knows G-tubes well, so they can make a determination what may be going on in your child's case, because there's about 5 or 6 reasons why leakage occurs.
Okay, thank you.
Hi, what are the hallmark signs that it's time to get a G-tube, and is it ever too late to get one?
The only time it's too late is if you're not able to function anymore, but so it's never too late. We have adults who get G-tubes, so the hallmark, there are a lot of different reasons, as I mentioned, for getting G-tubes. If in a young patient, we use the body mass index as and tracking that over time. If it's not just weight and height, but actually the body mass index. If the body mass index is falling off, then that's a sign of really significant growth failure, and that's probably the primary reason for us placing a gastrostomy tube.